Let's move on, if you don't mind, to second generation drugs. And Mark, I'm going to come back to you on the development of both quizartinib and gilteritinib in this setting. And of course, there's crenolanib if we have time.
So yes, these actually, the three drugs were kind of coming in parallel. Quizartinib is the older one that was designed specifically as a FLT3 inhibitor. And, it had a bumpy regulatory course, but they, finally emerged with this so-called Quantum R trial, taking patients who had, now quizartinib is a type 2 inhibitor. It does not inhibit the type 1, it does not inhibit the TKD mutations. Very specific for the ITD, very potent, very selective. And for patients with relapsed or refractory FLT3 ITD AML, they were randomized to receive kind of a conventional MEK or vicious salvage or LODAC or quizartinib as a single agent. And while that trial met its primary endpoint of overall survival, and the Japan regulatory agency thought that was fine, Europe and the US did not. There was wringing of the hands over, QT prolongation, this drug seems very toxic, which is startling to any of us who have given it compared to MEK chemotherapy. And their point was it wasn't a big enough improvement, and it really looked only good against LODAC. But again, we can quibble over that. The simple truth is it is an effective agent. And it is being studied, in a different context as well, in something called the Quantum First trial, which is up front, and we can talk about that. But that's quizartinib for the relapse refractory setting, a type 2 selective potent inhibitor. The other one is gilteritinib. Gilteritinib was developed, and I kind of like to use this analogy. The developers of gilteritinib watched all the mistakes made we were doing in quizartinib. And they just waited for us to spring all the traps and find all the screw ups. And then they just marched on through very rapidly and casually developed a very good drug, which is in fact a type 1 inhibitor. Less potent, but still very potent in vivo and really quite selective for the FLT3 mutations. And so it got approval, kind of across the world for the relapse refractory setting, and is now, of course, being studied up front versus midostaurin, in combination with chemo. Finally, oral crenolanib is still back there. Again, we're kind of waiting to see what's happening with that drug. And I think really the focus for practical purposes is still on quizartinib and gilteritinib.